So hello, my name is Dr. Akhilan. I'm mentoring anesthesia for the Speed Coaching Institute. So in this particular video, I would like to do a small review of the questions which has been asked in the last INI-CET exam, which is the INI-CET 2021 July session. Okay. So from anesthesia, 4 questions have been asked. All these 4 questions have been very simple, straightforward. But if you are not really sure about how to go about these 4 questions, probably this video is going to help you, right? So let us move on to the first question. The first question which was asked is, what is the mechanism of action of local anesthetics? Your options were, it blocks the sodium channels, it blocks the potassium channels, it blocks the calcium channels, and it blocks the chloride channels. So this is a very straightforward question. This question has been repeated multiple times in many exams over the period of years, So this is a very straightforward question, and your answer would be that it blocks your sodium channels. It is a straightforward, simple question. Now let me add a few more details here regarding the mechanism of action of your local anesthetic agents, right? So when you look at your local anesthetic agents, as I've already told you, the mechanism of action of local anesthetic agent is that it blocks your sodium channel. It blocks your sodium channel. So it is very simple. So what happens is, see, imagine that this is one particular cell, okay? Imagine that this is one particular cell, and you know that you are going to have a sodium channel here. And if the sodium channel is activated, it is going to let the sodium from outside go inside to the cell. So sodium is going to get transferred from outside of the cell to the inside of the cell if sodium channel is activated. Now this is going to lead to a positive electrical event which is called as depolarization, which will result in a positive mechanical event. Right? So what happens by blocking the sodium channel is that you are preventing sodium entry inside the cell, thus preventing depolarization from happening. So it is as simple as that. But if you look at the previous INI-CET questions, you have had a lot more complicated questions coming from this particular side. So I'd like to slightly elaborate on the mechanism of action of local anesthetic agents somewhat. Okay. So if you look at your sodium channel, let me draw a sodium channel here. So this is your sodium channel here. So if you look at your sodium channel, this is the outside of the cell and this is the inside of the cell. Okay. So you can see that in this particular sodium channel, you do have 2 gates. Okay. You do have 2 gates. So this is one gate here, and you also have one more gate, say here. Okay. So this particular gate is called as the activation gate, and this particular gate is what is called as the inactivation gate. So this is the inactivation gate. So once again, this is the sodium channel. This is just a schematic diagram of your sodium channel, and you can see that this particular sodium channel is having an activation gate and an inactivation gate. Now based on the configuration of these gates, your sodium channel can exist in 3 important phases. Your sodium channel can exist in 3 important phases. Okay. So what is the first phase? The first phase of your sodium channel is something which is called as resting phase. The first phase of your local anesthetic agent sodium channel is the resting phase. So how will the resting phase look like? The resting phase is going to look like this. Here again, this is the sodium channel. So in the resting phase, what is going to happen is your activation gate will be closed. Your activation gate will be closed. Your inactivation gate might remain open. So this is what is called as the resting phase. Okay. What is the second phase? The second phase is the activated phase. Second phase is the activated phase. So what do you mean by the activated phase? In the activated phase, you are going to again have the sodium channel here, and as the name suggests, the activation gate is going to remain open. The activation gate is going to remain open, and the inactivation gate is also going to remain open. The inactivation gate is also going to remain open. So because of this, what is going to happen is your sodium is going to easily enter from outside of the cell to the inside of the cell. It causes depolarization and it causes the activity which is required. So if you want depolarization to happen, if you want to feel sensations, if you want to have some motor activity, your sodium channel should be in the activated phase. But as far as local anesthetic drugs are concerned, we do not want this sodium channel to be in the activated phase. Okay. So let's go to the last phase. the last phase is something which is called as the inactivated phase. Last phase is something which is called as the inactivated phase. So what do you mean by the inactivated phase? Here also, if you look at the sodium channel, it is going to be like this. Here in your inactivated channel or inactivated phase, your activation gate is actually open, but the inactivation gate is absolutely closed. The inactivation gate is absolutely closed. So what does this mean? This means that it is not going to let the entry of sodium inside the cell. Now, what is the significance of understanding that your sodium channel has got resting phase, activated phase, inactivated phase? Because previously there was a JIPMER question. So I can say that this is a previous INI-CET question. They had asked that your local anesthetic agent, it blocks the sodium channel at what phase? Resting phase, activated phase, inactivated phase, both inactivated and resting phase. So when such a complicated question come from this particular section, you should be able to answer it. So that is why I've made you understand that your sodium channel actually has three important phases. It has got a resting phase, activated phase and inactivated phase. And your local anesthetic drugs, whichever that may be, it blocks your sodium channel in the inactivated phase, so please do remember this, or else remember that your local anesthetic agents causes sodium channel blockade in the inactivated phase or arrest the sodium channel in the inactivated phase. So this is something that you should remember about local anesthesia mechanism of action. So you know that the mechanism of action of your local anesthetic agent, it is by causing sodium channel blockade at the inactivated phase. Please do remember this particular fact. Now, second important information, you have something which is called as the onset of action. So what determines the onset of action of your local anesthetic agent? It is determined by one constant, dissociation constant, which is called as pKa. So onset of action of local anesthetic agent depends on one value of the drug, which is called as the pKa. What determines the duration of action of your local anesthetic agent? The duration of action of local anesthetic agent is determined by the protein binding tendency of your particular local anesthetic agent drug. It is by the protein binding tendency. Finally, what determines the potency of your local anesthetic agent? The potency is determined by your lipid solubility. So mechanism of action is sodium inactivation, onset of action is pKa, duration of action is protein binding, and potency of action is dependent on lipid solubility. For more conceptual understanding, please do go through the SPEED app where I have discussed the conceptual explanation for all these points. For the time being, remember these 4 factual points. It might be useful for you in your NEET exam. So that is all about the first question. Now let us move on to the next question. Now let's move on to the second question from your INI-CET exam, especially from anesthesia. So this is a question. Highest fraction of inspired oxygen is provided by which of the following? Your options were nasal cannula, non-rebreathing mask, face mask and Venturi mask. Okay. So here your correct answer is non-rebreathing mask. Okay, so we need to understand certain things about this question because this is a very relevant question considering the COVID pandemic situation, and non-rebreathing mask is one of the best instruments or tools that you have in your wards right now. So because of this particular fact, this is a question with high probability of being repeated in your NEET exam as well. So we need to understand slightly in depth regarding these different instruments. Okay, so before I go in depth regarding these instruments, I want to show you how all these looks like, so that if any image based questions come, you will be able to identify. Right, so the instrument that you are seeing here is something which is called as the nasal cannula. So this is the part which goes into the oxygen source, and this is the part which goes into the patient. So this is like other name for this is nasal prong. So this is directly going into the patient's nose. This is the normal face mask. Obviously you would have seen this in your wards, in the OTs, also in so many movies it would have come. This is a very common device. This is also a very common device. So this is nasal cannula and face mask. Now this is your non-rebreathing face mask. You can see that in your non-rebreathing face mask, you are having an additional reservoir bag. You are having an additional reservoir bag. I'll make you understand the function of this reservoir bag in a minute, but please do remember this is how a non-rebreathing face mask is going to look like. This is the answer to the question which was asked in INI-CET exam, which was recently concluded. Okay. And you also have certain other devices which is called as the Venturi face mask. So this is the Venturi face mask. Now how do you identify Venturi face mask, or how do you differentiate Venturi face mask from the other face mask that I showed you? Here you can see a color coding. You can see that this particular area is going to have some color. Either it can be yellow, it can be pink, it can be blue, it can be red or green. So there will be some specific color which will be located here, and that is how you identify Venturi mask. And you also have a device which is very similar to the Venturi mask, but something that you attach directly to the tracheostomy tube. So that is why it is called as trach collar. This is a very similar mask to Venturi mask, but this is something that you attach directly to the tracheostomy tube. So that is why it is called as trach collar. So these are the many devices that we use for oxygen delivery. Okay, so first part of our discussion here in this question is to make you visually identify these parts, because this is one probability of a visual based question that can come in your NEET exam as well. So please do remember these images, and now let me have a conceptual discussion of what is these devices. Okay, so we are going to talk basically about oxygen delivery devices. Okay, we are going to discuss about oxygen delivery devices. Oxygen delivery devices. So when it comes to your oxygen delivery devices, it is broadly divided into two. They are broadly divided into two. They are divided into normobaric oxygen delivery devices, normobaric oxygen delivery devices, and hyperbaric oxygen delivery devices. Hyperbaric oxygen delivery devices. Okay. Now this is an entirely different topic. We will discuss that in detail in our normal lecture class, but for the time being, let's focus on the normobaric oxygen delivery devices. Normobaric oxygen delivery devices. So what does this name mean? It means that in these group of devices, they deliver oxygen at atmospheric pressures to the patient. These group of devices deliver oxygen at atmospheric pressures to the patient, whereas hyperbaric oxygen devices, they deliver pressures at pressures which are higher than the atmospheric pressure. So that is why they are called as hyperbaric oxygen therapy or hyperbaric oxygen delivery devices. Now, when it comes to your normobaric oxygen delivery devices, they are also divided into two. Those devices which give out variable FiO2, those devices which give out variable FiO2, and those devices which can give out fixed FiO2. Those devices which can give out fixed FiO2. Those devices which give out variable FiO2 are your commonly used nasal cannula, your normal face mask, and also your non-rebreathing mask. Nasal cannula, face mask, non-rebreathing mask are examples of devices which deliver variable FiO2 to the patient. You also have devices which deliver fixed FiO2 to the patient. They are the Venturi mask and the trach collar. They are the Venturi mask and the trach collar. Okay, trach collar. Now, to identify or to understand why these devices deliver variable O2, we need to understand the functional analysis of all these devices. Okay, so let me make you understand how these devices exactly work. Obviously, to deliver oxygen to the patient, you need to have an oxygen source. To deliver oxygen to the patient, you need to have an oxygen source. So let that be a cylinder here, or sometimes it might also be the flow meter which is wall mounted. It can be an oxygen cylinder, or it can be the flow meter which is wall mounted. That will be acting as the source of oxygen. So from there, one small connection will come, and that will join your face mask or the instrument. So imagine that this is a schematic diagram of a face mask, which is a device which is non-rebreathing, which is a device which is delivering variable FiO2 to the patient. Now, so oxygen is going to flow from this particular source through this pipe into the mask. Now here you have the patient, you have the mouth and your nose of the patient, and you know that air is going to enter through the mouth and through the nose of the patient. Now mouth, nose and the upper airway of the patient, mouth, nose and the upper airway of the patient, they contribute to something which is called as anatomical dead space. They contribute to something which is called as anatomical dead space. Now, what is the significance of anatomical dead space in your particular variable FiO2 devices? They act as something which is called as reservoir. They act as something which is called as reservoir. I'll make you understand. You know that this is the mouth and the nose, and this is your upper airways. They together contribute to something which is called as anatomical dead space, which does not take part in any respiratory exchange. And then you have the lower airways, which eventually leads up to the lung. So this is your lower airways, and then you have the lung, right? Lung. So your anatomical dead space or your upper airways and the mouth and nose, they will act as your reservoir. Means when you connect the patient to your particular oxygen source using a face mask or a nasal cannula or a non-rebreathing mask, initially flows will happen, and this flow is going to fill up your reservoir here. It is going to fill up your reservoir here. So this is what? This is oxygen which is coming directly from your oxygen source. It is oxygen which is directly coming from your oxygen source. So this face mask is delivering pure oxygen, and that pure oxygen is now accumulating in your mouth and nose and also the upper airways. This is 100% oxygen. Yes or no? This is 100% oxygen, because this is pure oxygen which is directly coming to this area from your oxygen source. Okay. Now, when you breathe, what happens is you apply a negative pressure. The lung and the lower airways, they apply a negative pressure like this, which draws air from your anatomical dead space as well as from the atmosphere into the lung. Okay, so when you are breathing, what is going to happen is some amount of air will be drawn from your anatomical dead space and some amount of air will be drawn from the atmosphere, and a minimal amount will be going to the patient from the air which the patient had already expired. So if you look at what is the air which is going inside the patient at one particular point of time, it is going to be the air which is present in the anatomical dead space, which was the reservoir which got already filled. Right, which got already filled, and that contains 100% FiO2. The patient is also going to inspire a lot of air which is present in the atmosphere as well. So it is going to take atmospheric air, and you know that in atmospheric air the FiO2 is 21%. FiO2 is 21%. Also, the patient is going to rebreathe some amount of air the patient had just breathed out. So there is going to be some contribution from rebreathed air. Some contribution from rebreathed air. You remember that rebreathed air will have more carbon dioxide and lesser of oxygen, so its FiO2 will even be lesser than 21%. So at any point of time when the patient breathes using one particular device like a face mask or a nasal cannula or an NRM, the patient is actually breathing a mixture of three kinds of FiO2. 100% FiO2 which is present in your anatomical dead space, the atmospheric air as well as the rebreathed air. So you actually cannot predict what FiO2 is correctly going inside the patient. It is going to vary. This particular FiO is going to vary depending upon your respiratory effort, depending upon the patient's respiratory effort. So if the patient's respiratory effort is good, higher FiO2 might go to the patient. If it is not good, lower FiO2 might go to the patient. So that FiO2 that you are delivering is not really under your control, it is under the patient's control. That is why these devices, which are variable FiO2 delivering devices, can only be used for the treatment of mild to moderate hypoxia. It can only be used for the treatment of mild to moderate hypoxia. It cannot be used for moderate to severe hypoxia, or it cannot be used for the treatment of respiratory failures. If the patient is having mild desaturation, you can try applying these devices. Okay. Now, let me make you understand the factual points which are required for you to give the exam. You have a device which is called as nasal cannula, you have a device which is called as face mask, you have a device which is called as NRM. Okay, so these devices, they deliver only variable FiO2. How much FiO2 can a nasal cannula maximally deliver? The maximal FiO2 that your nasal cannula can deliver is only 40%. So if you are using a nasal cannula, how much FiO2 can you maximally deliver to the patient? Only 40%. And how much can a face mask deliver? A face mask can only deliver 60% of FiO2. Maximum, the range is actually 55 to 60% FiO2, but you can remember it as 60% FiO2. And when it comes to NRM mask, which is the answer to the question which was asked, the FiO2 can go up to 80 to 95%. I'll make you understand why it gives a higher FiO2. But before that, how do you memorize this? You memorize this very, very easy. So it is 40, 60, 80, Nasal cannula, face mask, NRM, it is 40, 60, 80. So please do remember like that. There is one more parameter which you should by heart when it comes to these devices, which is the maximal flow rate that you can give. So when it comes to your nasal cannula, the maximal flow rate that you can give is only 6 liters. What happens if you give flow rates which are more than 6 liter per minute? If you are giving flow rates more than 6 liter per minute to the nasal cannula, what is going to happen is it is going to cause dryness of your nose. It is going to cause epistaxis and nasal irritation. So you do not want that to happen. So that is why your nasal cannula has got a limitation, and that is in terms of the flow rates that you can give. It can only give 6 liter per minute flow. Okay. When it comes to your face mask, you can give a flow rate between 5 to 10 liter per minute. 5 to 10 liter per minute. What happens if you give flow rates less than 5 per minute? If you are giving flow rates less than 5 per minute using your face mask, the patient will rebreathe the patient's own expired air. The patient will rebreathe the patient's own expired air, which will again reduce the FiO2, and that is something that you do not really want. So that is why a minimal flow of 5 should be kept if you are using a face mask, and the maximum flow is 10 liter per minute. Why can't you give flow rates more than 10 liter per minute? If you are giving flow rates more than 10 liter per minute, it is only going to cause leakage of air into the atmosphere. So it is not really going to help your cause. It is only going to cause oxygen wastage. So the ideal flow that you can achieve with your face mask is something which is between 5 to 10 liter per minute. And finally, when it comes to your NRM mask, you can give slightly higher flow rates, which is 10 to 15 liter per minute. 10 to 15 liter per minute. So these three devices, they are called as variable FiO2 devices. They are also called as low flow variable FiO2 devices, because you always have a limitation to the flow that you can achieve with these devices. How do you remember? Nasal cannula, even though it is 6 to be most accurate, you can remember it as 5. So nasal cannula is 5. A face mask is 5 to 10, and your NRM is 10 to 15. Very, very easy for you to remember. And what about the FiO2? 40, 60, 80. Now, when I say 80, it can even go up to 80 to 95%. 80 to 95%. Now, why do you think your NRM mask can give higher flow rates? Why do you think your NRM mask can give higher flow rates? Let me take you back to this particular image here. This is your NRM mask, right? So, if you look carefully here, let me draw it out for you. What is actually happening here? Again, you are going to have an oxygen source. It might be cylinder, or it might be the flow meter which is mounted in your wall, and that flow meter is now directly attached here with your particular face mask. It is also attached directly to your rebreathing mask. It is also attached directly to your rebreathing mask like this. Now what is going to happen is, as I've said before, the anatomical dead space is here, the lower airways and lungs are here. So when the lower airways and lung draw air from the anatomical dead space and from the atmosphere, instead of the atmosphere, air from the reservoir bag will be taken by the patient. Now, as the oxygen travels here through this pipe into the face mask, it also goes up and passively fills up this reservoir bag. So, this reservoir bag is only containing 100% FiO2. So, instead of drawing air from the atmosphere, which is only containing 21% of oxygen, you have the luxury, or the patient has the luxury, to draw air which is present in your reservoir bag, which is again 100% oxygen. So, you have a higher chance of providing higher FiO2 to the patient, and depending upon the patient's inspiratory effort and depending upon the flow that we are giving, you can achieve a FiO2 of 80 to 95%. This is why NRM provides maximum FiO2, and among all these devices that I've told you, the device which is most commonly used, the most effective device in COVID-19 disease is also your NRM mask. That might also be a question which might come in your NEET exam. Right, so I have finished one section of devices, which is your low flow variable FiO2 device, and finally I would like to talk something about this particular device here, which is called as the Venturi device or the Venturi mask, because it has got a lot of questions here as well. So let me talk a little bit about your particular Venturi mask. Okay, so I'm going to talk about Venturi mask. Let me talk about Venturi mask and its mechanism of action. Now, your Venturi mask is based on one physical principle which is called as the Venturi effect, which is based on one principle which is called as Venturi effect. Now remember, Venturi effect is responsible for so many things in your medical practice, like it is the physical principle by which your nebulization works and so many other things work. Okay, so it is based on a physical principle which is called as Venturi effect, which in turn is an adaptation of further a physical principle which is called as Bernoulli's theorem. Okay, it is based on a theorem which is called as Bernoulli's theorem. So I want to make you understand what Bernoulli theorem is. I want to make you understand what Venturi effect is and what is the significance of Venturi effect in Venturi mask. Okay, so let me first make you understand what is Bernoulli's theorem. So I'm drawing a cylindrical pipe here. And at one particular point of time, the cylindrical pipe is facing a constriction. Okay, so this is a larger cylindrical pipe which is A, and this is a smaller cylindrical pipe which is B. Now I'm making something flow through this cylindrical pipe. May that be air, may that be liquid. For this particular purpose, I would like to consider it as air. So I'm making air flow through this particular larger tube here, and at one particular point of time, this airflow is now encountering some resistance or a constriction. Now what happens to the characteristics of airflow once the airflow enters from the larger pipe to the smaller pipe? That is what Bernoulli theorem says. It states that when the flow changes from a larger pipe or it faces a constriction, there is going to be increased velocity. There is going to be increase in velocity. At the same time, it is going to cause a decrease in pressure. So when gas or air moves from point A to point B like this, it is going to encounter an increase in velocity, but it is also going to encounter a dip in pressure. This is what is called as Bernoulli's principle. Okay, now if I make this Bernoulli's principle slightly, if I just slightly modify this Bernoulli principle like this, imagine this is again the same tube here, this is again the same tube here, this is the larger pipe which is going like this, and the larger pipe is eventually ending up in a smaller pipe. So in the smaller pipe, instead of keeping it totally closed like before, what if I keep a small opening here? What if I keep a small opening here? The same Bernoulli principle is going to apply here, which means that as the airflow happens from point A to point B, because of a constriction, it is going to have an increased velocity. At the same time, there is going to be dip in pressure. Now you are having a dip in pressure at the point of constriction. Yes or no? You are having a dip in pressure at the point of constriction, and that is where you have kept this particular hold. Now this dip in pressure and the hold together will create something which is called as negative pressure. So because there is a small or a slight dip in pressure here, which is going to cause a suction effect here in this particular opening. Okay, so this opening now will act as a negative pressure suction so that it draws air from the atmosphere. So this is what is called as Venturi effect. It is slight modification of your Bernoulli's theorem. What it states is that if you keep a hole at the point of constriction, that will, because of the pressure drop which is happening on the inside, this hole now will act as a negative pressure suction apparatus which will draw the air from outside into the inside. Okay, ideally what do you expect? If you keep an opening in a hole, if you keep an opening in a cylinder, that should actually cause leakage outside, right? But if you are keeping the hole at the point of constriction where there is a pressure drop, it is going to draw air into your small pipe. This is what exactly is happening here in your Venturi mask. Let me make that more clear considering the mask scenario here. Okay, so this is your phase, this is your oxygen cylinder source here, and from the cylinder source I am connecting a larger pipe like this, and then suddenly at one particular point of time I am keeping a small constriction, and that small constriction is happening having a hole as well. Now here from the oxygen source, pure 100% oxygen was traveling like this, pure 100% oxygen was traveling like that at one particular pressure and on one particular velocity, As it encounters a restriction or a constriction, the velocity is going to increase, the pressure is going to dip. And because you are having an opening, it is going to now, what is it going to do? It is going to trap some atmospheric air like this before it reaches the face mask. So it was 100% FiO2 that you were initially delivering the patient. Now because of the constriction, some atmospheric air has entered inside the system, so the FiO2 is now going to get diluted. The FiO2 is now going to get diluted. So the FiO2 will be diluted. FiO2 is going to be diluted. Now this is something that is going to happen, but if you apply science and physics to it, you can adjust the size of this aperture. If you adjust the size of aperture, you can adjust the amount of air that is going to come inside. And if you can adjust the amount of air that is going to come inside, you will also be able to adjust the FiO2 that is exactly delivered to the patient. So you adjust the aperture, you adjust the amount of air that is entering inside, and that is how you adjust the FiO2 to a fixed FiO2. That is what your Venturi mask is doing. Okay, so you have Venturi mask with different apertures which can provide different FiO2 to the patient, and that is why you have color coding here in your Venturi mask. So this is your Venturi mask here. You can see that there is so many color coding here, and these color codes actually indicate the different sizes of the aperture which is kept here in this particular area, so that differential air absorption or air entrapment will happen, and these different colors deliver one fixed FiO2 to the patient. For example, if it is red colored Venturi mask, it will deliver 40% FiO2 to the patient. If it is green colored Venturi mask, it will deliver 60% FiO2 to the patient. Similarly, these Venturi mask, they can actually deliver FiO2s which are in the range of 24 to 60%, which are in the range of 24 to 60%, and you will have color coding to identify these Venturi masks. For the time being, just understand that maximum FiO2 is delivered by green colored Venturi mask. Green colored Venturi mask delivers maximum FiO2 which is 60%, and the second best is your red colored Venturi mask which can deliver only 40%. Okay, so coming back to the question, nasal cannula only 40%, non-dilating mask it can deliver 80 to 90%, then your normal face mask only 60%, Venturi mask maximum green color only can deliver 60%. So I hope you have had a conceptual understanding of these devices, normobaric oxygen therapy devices. There is a high probability that questions might again come from this section for this coming NEET as well, right? So that is about the second question. Now let's move on to the third question. What is the gauge for given image of IV cannula? 18, 20, 14, 16. So you are seeing a green color here. So they are asking the gauge for this particular IV cannula. Very, very good question. Very simple question. Probably the most commonly used IV cannula in operation theaters and ICU, which is the green colored cannula, and the correct answer is 18 gauge. Now this might seem very difficult at this particular point of time to remember all the colors, but there is a very common image that many people have been using over the years to by heart the gauge colors and the color coding of these IV cannulas. So if you are not really aware of that picture, I'll help you to memorize all these values. Okay, so before I make you understand these values, let me just make you look at all these IV cannulas which are available. You can see that your 14 gauge IV cannula is orange in color, then you have a 16 gauge gray color, 17 gauge white color, 18 gauge green color, 20 gauge pink, and 22 gauge blue, and 24 gauge is yellow. Now this might seem very difficult to by heart if you are not really aware of one particular image which is doing the rounds right now. Very, very simple image. So let me try to recreate something. I hope you will be able to understand this. Okay, so let me draw something here. So the first thing that I'm drawing here is here. Let me draw it first here. So I'm drawing something here. Okay, so this is something which I can call it as the lava which is present underneath your soil. Okay, this orange color thing is something which you can call as the lava which is present underneath the soil. And then once you are having the lava, or above the lava, what do you have? You again have something which is called as the soil. So this is the soil which is present above the lava, which is nearly gray in color, And what do you have above the soil? Above the soil you have a very, very beautiful plant, and you know that plants are green in color. plants are green in color. Yes or no? Plants are green in color, right? So this is a beautiful plant. And then what do you have? In the plant, you have a very, very beautiful flower just like this. You have a beautiful flower here in this thing. And it is a bright blue day here with blue skies. So let me just recreate a blue sky here. Let me just recreate a blue sky here. I hope you are sure with this image, or you might have heard or like seen this image before. If not, this image is going to really help you memorize the ivy gauges, right? So this is your bright blue sky which is above the plant shining, and you are having a bright sunny day, so you are going to have sun like this. You are going to have sun like this. So this is the image that I want you to remember. Okay, this is the image that I want you to remember. Okay, now let me just put some colors and let me just make you understand these things. So this particular color that you are seeing here is orange, right? So this is the lava which is present beneath your soil. Then this is your gray colored soil. You are having a green colored plant, above which you are having a pink colored flower, above which you are having bright blue sky, and then you are having the yellow colored sun, right? Yellow colored sun. And you start with the number 14 here. So 14, 16, 18, 20, 22, 24. So this is how you easily memorize all these ivy gauges. Okay, so the first part of the job is easily done. You just need to understand that this is how you remember the ivy gauge lines. Okay, so here I've missed one here, and that is the white colored ivy cannula. Okay, white colored ivy cannula, which is very, very rare, which is not really used anywhere. It is 17 gauge. Okay, white colored ivy cannula is 17 gauge. It is not really used. And if you want further information, there is one more ivy gauge that I can give you, which is the 26 gauge ivy line, and the color for that is purple or violet. Purple or violet. It is also not clinically used. Most commonly used ivy gauges are pink, green and blue. And for neonates also you use yellow. That is it. Okay. So these are the ivy cannulas that we are using. Up to green, up to 18 gauge, these IV cannulas are called as wide bore IV cannulas. Up to green, it is called as wide bore IV cannulas. And anything that is starting from pink, 20, 22, 24, 26, they are all called as narrow bore or small bore IV cannulas. Narrow bore or small bore IV cannulas. IV cannulas. Okay. So as a general principle, you should understand that higher the gauge, smaller the diameter, smaller the flow rate. Or in other words, flow rate is inversely proportional to the gauge. Diameter is inversely proportional to the gauge. So smaller the gauge, larger will be the diameter, higher will be the flow. Okay, so the first part of this question, because you are having a lot of match the following questions in INI-CET right now, it is very important that you by heart all the colors, and by hearting the colors is very, very easy if you remember this particular image. Okay, if you forgot this, this is lava here, this is the soil, this is the plant, flower, sky and sun. Okay, this image will make you easily understand your particular colors of your IV cannula. Now, next thing is to remember the flow rates of this IV cannula. Next thing is to remember the flow rates. The basic principle guiding flow rates are inversely proportional to the gauge. So, smaller gauges will have higher flow rates, right? So, how do you remember that? How do you remember that? Let me just write down orange, starting from orange here, okay? Starting from orange, then gray, then you have something which is called as white, then green, pink, blue and yellow, right? Blue and yellow. You know the gauges already: 14 gauge, 16 gauge, 17 gauge, 18 gauge, 20 gauge, 22 gauge and 24 gauge. Okay, now what we have to remember is regarding the flow rates. Now I have a technique of remembering this. This is not exactly accurate information, but this is enough for you to pass the exam. Okay, so remember that orange colored IV cannula, which is the largest bore IV cannula that is available, it has a flow rate of 250 ml per minute. What does this mean? It means that you can finish 1 liter in just 4 minutes if you are using orange colored IV cannula. 250 ml in 1 minute. Okay, 250 ml is the flow. Now this is 250, right? So you remember gray as 2 25 ml per minute. Very, very simple. 250, 225. Then how do you remember white? White is having 200 ml minute. So orange, grey, white are all at distance of 25 ml per minute. So it is 250, 225, 200. Please do by heart this now itself when you are listening to this class. Okay. Now when it comes to green, reduce it by half. When it comes to green, reduce it by half. Reduce it to 100 ml per minute. 100 ml per minute. Now remember that the actual value is 90 to 100. But for remembering purpose, they are not going to ask you what is the flow rate green colored cannula 91, 92, 93, 94. They are not going to ask you. They are only going to ask a specific range. So remember it as 100 ml per minute. Okay. This is about green. Now for pink, again reduce it to half, which is 50 ml per minute. Again, please do remember the original rate is 50 to 60 ml per minute. Okay. Or it will be even more exact, it is 54 ml per minute. That is what is recommended of your pink IV cannula or 20 gauge IV cannula. Okay, 50 ml per minute. Please do remember like that. So half, half, half. First 25, 25, 25, then half, half, half. Then when it comes to blue, you can reduce it to 40 ml per minute. And when it comes to yellow, it is 20 ml per minute. 20 ml per minute. Now, is it important to by heart this value? It is absolutely important. For going forward, INI-CET exams are going to have match the following questions, so they can definitely ask this along. So at least do remember the range. So that is why I want to give you a near value, but that will enable you to by heart this easily. Okay, so IV colors, very, very easy to identify. IV flow rates start from 250, 225, 200, then 100, 50, 40, 20. Right? And if you want for violet or purple, if you want flow rates for violet or purple, which is 26 gauge, it is just 10 ml per minute, which is exactly half of yellow as well. Okay. So this is how you remember the IV cannulation colors and IV cannula flow rates. Right. One more slight conceptual adding that I would like to do. I mentioned that the flow rate is inversely proportional to the gauge and stuff. There is one important physical principle which guides the flow of liquid through your IV cannula. That physical principle can come as a factual question, and that physical principle is what law? Hagan Poisoning Law. See, Hagan Poisoning Law has not been formed for your IV cannula. It is just the law that governs the flow, laminar flow of fluid through a cylindrical pipe. Whatever may be the fluid, whatever may be the gas, if it is flowing through a cylindrical pipe in laminar fashion, then it will obey Hagan Poisoning Law. And in our body, we only appreciate laminar flow happening. When the IV fluid is connected to the patient using the IV cannula, we are only appreciating laminar flow, and because it is laminar flow, it will only depend on Hagan Poisoning Law. And what does Hagan Poisoning Law says? That whenever there is flow of liquid or air through a cylindrical pipe, it is going to encounter a resistance, or there is going to be a pressure drop, or in physical terms it is called as head loss. Pressure drop, head loss, or resistance, all these are equal to or is directly proportional to, or it is directly proportional to the viscosity of the gas or the liquid, the length of the tube, and inversely proportional to the fourth power of radius. So if you increase the diameter, the flow is going to increase much more, the resistance is going to come down. This is what it means. Hagan Poisoning Law, the pressure drop or the head loss is directly proportional to the viscosity of the gas or the directly proportional to the length of the tube, and inversely proportional to the fourth power of radius. This is the law which governs the factors which affect flow through your IV cannula, right? So that is all about IV cannulation that you should remember based on the question which has come. And about the question, as I said, among all the colors, they have used the most commonly used color. So that is something that I appreciate out of your INI-CET exam. So I hope this particular concept is clear for you. Now let us move on to the next question. So moving on to the last question. This is an image based question which has come from Anaesthesia. In the image of the above given monitor, the number marked with arrow indicates the measure of. So you can see that this arrow is pointing at one particular value which is written as 38 here, and you can see one particular waveform that is along with that particular value. Yeah. So in the image of the above given monitor, the number marked with arrow indicates the measure of oxygen pressure, carbon dioxide pressure, C airway pressure, D bispectral index. The answer to this question is very, very obvious. It is carbon dioxide. It is carbon dioxide. Now, please do remember something about this particular question. Now, capnography is probably the hottest topic in anesthesia. If you look at the last NEET exam, they had a question in capnography, which was image based. Again, previous year NEET also, they had a question from capnography, which is image based. So one question which I can say with sure shot guarantee that might come to you in your NEET exam is also capnography. They might give you, actually the questions which come from capnography are even more complicated. They'll give you a waveform and then ask you to diagnose the condition. So that was what was happening from the last year. So this is a very simple straightforward question in capnography. All you are supposed to do here is to identify that particular waveform and that number, right? So the answer to this question is carbon dioxide, right? So let me tell a very small, let me just give you a very small introduction to capnography, because it is a very detailed topic. All the conceptual understanding of capnography can be done by going through my lectures in the Speed app. So let me just give you some introduction about capnography. Okay, so capnography is essentially what? Capnography is nothing but a respiratory monitor. It is nothing but a respiratory monitor. Okay, it is nothing but a respiratory monitor. What does it measure? It measures the end tidal carbon dioxide. It measures a value which is called as end tidal carbon dioxide. What do you mean by end tidal carbon dioxide? It is the partial pressure. It is the partial pressure of carbon dioxide in expired air. It is the partial pressure of carbon dioxide in the expired air. Because it is the partial pressure of carbon dioxide in the expired air, the value that you get as the reading will be in millimeters mercury. The normal range is between 35 to 45 millimeters of mercury. Now this is a question which has been asked multiple times in many exams all over our country. So the normal value of your capnograph is 35 to 45 millimeters mercury. So this particular monitoring is what is called as capnography, and this numerical value that you have obtained as a result of this monitoring is what is called as capnometry. Right? So it measures end tidal carbon dioxide, which is the partial pressure of carbon dioxide in expired air. Okay. Now, next important thing, why do you think we are measuring carbon dioxide or end tidal carbon dioxide? We are measuring end tidal carbon dioxide as a surrogate of understanding regarding PaCO2, which is the partial pressure of carbon dioxide in your arteries. We are measuring end tidal carbon dioxide as a surrogate to measuring PaCO2. Now, if you want to measure PaCO2, we need to do ABG, and you cannot do that all the time in the perioperative period. So just to have an idea about what the PaCO2 could be, we are measuring your end tidal carbon dioxide. So ideally, EtCO2 and PaCO2 values are more or less normal. There might be slight variations. The difference that can maximally happen between your PaCO2 and end tidal carbon dioxide is 2 to 5 millimeters of mercury. Now, is it important to remember this particular value? It is important to remember this particular value because this is also an entrance question which was previous year question. This is actually a NEET super speciality question. What is the difference between PaCO2 and EtCO2? Okay, so because this question now is repeatedly coming in your exam, this is also a probability to be asked in your normal NEET PG exam as well. Okay, right. Now you are measuring end tidal carbon dioxide as a surrogate of understanding regarding PaCO2. Now what is the significance of understanding PaCO2, or what is the significance of understanding regarding carbon dioxide? Why do you think it is so much helpful for us? Okay, so to understand that, you should understand that carbon dioxide is eliminated by which system of your body? Carbon dioxide is eliminated by your respiratory system. Carbon dioxide is eliminated by your respiratory system. So if you look at the carbon dioxide value, you will know how your respiratory system is properly functioning. Or in fact, carbon dioxide elimination is more importantly a function of respiratory system, which is called as ventilation. So if there is adequate ventilation, carbon dioxide elimination will be normal. If there is inadequate ventilation or hypoventilation, there will be inadequate carbon dioxide elimination, which will cause increased PaCO2 values, which will cause increased EtCO2 values. Yes, so you'll know whether the patient is having some kind of hypoventilation going on. You'll also know whether the patient is going in for hyperventilation or carbon dioxide washout. So actually carbon dioxide elimination is a function of ventilation or a function of your respiratory system. So you will know some idea about respiratory system by just looking at the carbon dioxide value. Also, carbon dioxide, how do you think carbon dioxide is produced inside your body? Carbon dioxide is produced by metabolism. Yes or no? It is the end product of aerobic metabolism inside your body. If you are having hypermetabolic states, say if you are having hypermetabolic states like say hyperthyroidism, or more importantly for an anesthesiologist, you have a very dangerous fatal hypermetabolic condition which is called as malignant hyperthermia. So these conditions are hypermetabolic states. In these hypermetabolic states, there is going to be increased production of carbon dioxide, and by looking at the capnometry value, you'll know whether the patient is ending up in malignant hyperthermia. In fact, the first sign of malignant hyperthermia is elevation of end-tidal carbon dioxide. You'll also know about hypometabolic states. You'll also know about hypometabolic states like hypothyroidism, where you know the patient is actually having inadequate carbon dioxide production. So like hypothyroidism. So it gives you idea about the respiratory system, it gives you idea about the metabolic system, it also gives you idea about one more important system. Now you know that carbon dioxide is a metabolic byproduct or a waste product. From that tissue level, it will be taken to your respiratory system through your circulatory system. So if your circulatory system is inadequate, again the carbon dioxide value can be variable, right? So it also gives you idea about the circulatory system of your body. It gives you idea about the circulatory efficacy of your body, and because it gives you the idea about circulatory efficacy of the body, even American Heart Association recommends the use of end-tidal carbon dioxide during CPR to see if there is if your CPR is quality, or if the quality of the CPR is good enough, or if the patient is having return of spontaneous circulation. For that purpose, even your particular AHA is recommending the use of end-tidal carbon dioxide. Also, you will be able to diagnose certain circulatory conditions like pulmonary embolism using your end-tidal carbon dioxide value. So with one single monitor, you are getting multiple information about multiple systems. That is why it is now considered to be one of the 5 standard monitors that must be present when the patient is undergoing surgery under general anesthesia. Okay, so this is the significance of understanding end-tidal carbon dioxide. It gives you a lot of information. Now I just want to give you a small idea regarding this particular waveform that you are seeing here. What is the genesis of that waveform? If you identify how that waveform happens, then you will be able to identify the different conditions, or you will be able to troubleshoot the different patterns which might happen in your capnograph. Okay, so let me just redraw that graph here. So this is how it looks like. Okay, now please do remember that this is a graph. Graph means it will have an x-axis and a y-axis. So in this capnograph, what is the x-axis, what is the y-axis? Okay, so let me just draw it into a graph here. What is the x-axis and what is the y-axis? The x-axis here is going to be either time or volume. The y-axis is going to be your end-tidal carbon dioxide. If time is the x-axis, component of your x-axis, it is called as time capnogram. If volume is in the x-axis, it is called as volume capnogram. Now we are only going to be concerned about time capnogram. I'll just make you understand the genesis of time capnogram. Remember, what is your end-tidal carbon dioxide? It is the partial pressure of carbon dioxide eliminated, or it is the partial pressure of carbon dioxide in your expired air. So we will trace out expiration with time. We are going to trace out expiration with time, and we are going to see how the carbon dioxide level changes along with expiration with time. Okay. So imagine you are someone who is breathing out, any patient, or you are breathing out. What is the first air that is going to come out? The first set of gas that is going to come out while you are expiring is the gas which is present in your anatomical dead space. Yes or no? The gas which is going to be present in your anatomical dead space. Right? Anatomical dead space. Now what is the speciality of anatomical dead space? Anatomical dead space has not participated in respiratory exchange. So it has not participated in respiratory exchange. Because it has not participated in respiratory exchange, it is not going to contain any carbon dioxide. Yes or no? So the first gas that is going to come out of your from your nose during expiration will not contain any carbon dioxide. So I'm tracing expiration here. Here is the initial part of expiration, and in the initial part of expiration there is no carbon dioxide, so it keeps along the baseline because it is just the elimination of anatomical dead space air. Now what happens after a period of time is that after some time, during the second phase of expiration, along with the anatomical dead space air, some amount of alveolar air will also now get eliminated. Some amount of alveolar air will also now get eliminated. Now alveolar gas would have taken part in respiratory exchange, and it will definitely contain carbon dioxide. Yes or no? It will definitely contain carbon dioxide. So during the second phase of your expiration, where there is elimination of anatomical dead space gas along with alveolar gas, there is going to be traces of carbon dioxide present, and that is why I am going to mark here. There is going to be a slight rise in carbon dioxide like this, right? So after some time, during the third phase of expiration, what is going to happen? All the anatomical dead space gas would have been washed out or expired out. Remaining is only going to be your alveolar gas. As I have mentioned earlier, alveolar gas would have definitely taken part in respiratory exchange. It would have definitely be containing carbon dioxide. But the difference here is, because now there is no mixture of gas, it is only alveolar gas, and the alveolar content of carbon dioxide is supposed to be more or less same in all the alveoli. Yes or no? Because you consider the V by Q to be a constant for all your normal alveoli. So the amount of carbon dioxide that is present in all these alveoli can be somewhat constant, and because the alveolar content of carbon dioxide is constant, the alveolar elimination can be more or less constant. That is why in the third phase of your capnography, you are getting a plateau-like phase. This is elimination of carbon dioxide which is happening from the alveoli alone. Okay, this is the third phase of expiration. Now once you are done with alveolar gas elimination, your expiration is over, then you are going to inspire again, and when you are inspiring, you are not really going to inspire any carbon dioxide. So there is going to be a sudden dip in this particular graph, which is going to be like this. Your graph is going to come down like this, right? So this is why this graph will look like this. Now I want to give certain nomenclature to here. This is the first phase of expiration, so this is actually marked as 1. This is the second phase of expiration, where there is mixture of elimination of carbon alveolar gas and anatomical dead space, and this is your phase 2 of capnogram. This is the phase 3, which is the plateau phase of your capnogram, which is concerned with elimination of alveolar gas alone, and this is the inspiratory phase, and I am going to mark inspiratory phase as 0. This is the latest nomenclature for the phases of your capnograph. Please do note. Also note that this 0 is going to continue somewhat here, and after one point again the first phase is going to get repeated. So this is 0 contains this much and 1 contains this much, because inspiration continues for some time as well, then expiration begins. Okay, so the baseline is shared by phases 0 and 1, right? So this is the genesis of this particular graph. Now I want to just give you one more information. If you can see here, there are two angles which are formed here, right? This angle is called as the alpha angle. This angle is called as the beta angle. The normal value of alpha angle is 110 degree. Normal angle of beta degree is 90 degree. Now it has to be 90 degree here, because this is the angle which is formed between expiration and inspiration. And in inspiration, you do not expect any sort of carbon dioxide. If the angle, beta angle is more than 90 degree, it means that there is some amount of carbon dioxide which is present in your inspiration, which is called as rebreathing, and which is something that you do not really want. Okay, so in this particular question, I had just only discussed about the normal genesis of the normal capnogram image, which is the time capnogram. If you look at our speed app, where we have discussed in detail regarding the various patterns which could arise and how to diagnose that using your entitled carbon dioxide values and graphs, that you have to just please subscribe the speed app and see in detail in the Anaesthesia lectures app. Okay, so that is about these questions, 4 very simple straightforward questions. If you are not really able to answer the questions, do not worry, you still have a chance. You can crack it in the NEET exam. Okay, so thank you. I hope this video was useful for you. Please do subscribe the speed app for such conceptual explanation of all topics. Thank you.